The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to Question Lab. We're happy to have you here this evening as we discuss the topic of renal. And leading tonight's discussion is Dr. Paras Vakari, and he's going to introduce himself to you now. Paras.
Thank you, Sean. Hey guys, my name is Paras. I'm an assistant professor in dermatology. I'm also an RX coach with USMLE-Rx. So help out leading sessions such as this and walking you guys and dissecting questions. Happy to help lead tonight's session.
So without any further ado, let's go ahead and get into our first question of the evening. As you can see, the answer choices are covered up. That is by design. We do that because we don't want the answer choices to dictate or guide your thought process. We don't want you to see an answer choice that you're unfamiliar with. That may cause you to panic as you're trying to answer the question on test day. So as you can see, those have been removed. After that, we begin with the lead-in, which is the last sentence or the question itself. And we do that so that you know what the test writer is asking when you read that vignette, so you can pick up on all of those relevant clues and not have to reread that question and waste time on test day. So without any further ado, let's take a look at that lead-in. The medication most likely used to treat this patient's symptoms will also have which of the following effects? The medication most likely used to treat this patient's symptoms will also have which of the following effects? After this, we'd like to ask our students how many steps each question requires. We do that to make sure you keep an organized thought process. An example of a one-step question could be where you ask for the diagnosis. An example of a two-step question is when you're asked for the treatment for a diagnosis. And an example of a three-step question is when you're asked for the mechanism for a treatment for a diagnosis. So we'll give all of a few seconds here to let us know in the question box how many steps you believe this question will require, and then we'll take a look at that vignette. All right, we'll give you a couple seconds here to let us know in the question box. Once again, if it's a one-step, two-step, or three-step question. All righty, let's take a look at that vignette. A 37-year-old woman develops polyuria one day after resection of a pituitary adenoma. Serum creatinine and glucose levels are normal. Urine osmolality is 100. The medication most likely used to treat this patient's symptoms will also have which of the following effects? Paras.
Thank you, Sean. So what we're going to do is we're going to go ahead and show you what we think are the important clues in this in this vignette and the lead-in. Okay, so you can see this is kind of a shorter question, so we know that there are going to be clues there that are going to be very important. Okay, now in this case, the first thing we're told are demographics, and a lot of times in these clinical questions, the first thing you're going to get are demographics, and you want to make note of that because that can automatically start to clue you in on things you should be thinking about. Okay, so we know this is a 37-year-old woman, and they tell us right off the bat that she's got polyuria, and they tell us a very important clue. This occurred one day after taking out a pituitary adenoma. Okay, so we know that there's going to be something going on here with levels in the blood, and we can tell that the next couple sentences give us some levels that we need to kind of interpret. Okay, and then they're asking us about the medication that would be most likely used to treat this patient's symptoms. Okay. But not just that, what effects will that medication have? So I think we've got a couple steps here. I think one, we've got to figure out, what is going on in this patient. Two, what medication will most likely be used as a result? And three, what are some other effects that medication will have? So I think we actually have a three-step question here. Okay. So let's go ahead and let's take a look at those answer choices. And what we see here are 5 answer choices, okay? And when we work with students, we actually recommend that they start at the bottom and work their way up to the top. So start with answer choice E and work their way up to answer choice A. And the reason we do this is because a lot of times we'll see students who they'll start at the top, they'll see something they like, and they'll select it without going through all the answer choices. So as a result, they'll sometimes get that question wrong. So we recommend doing it this way to prevent yourself from making that mistake and to not bias yourself. So let's go ahead and let's do that now. Answer choice E, relaxes vascular smooth muscle cells. D, reduces aquaporin insertion into principal cell membranes. C, lowers blood pressure. B, increases von Willebrand factor. And A, increases urinary sodium excretion. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Excellent. Thank you very much, Boris. The poll is open. We'll give all of you a few moments here to respond. We generally will wait until about 2/3 of you have responded. Keep in mind that, when you're taking your board exams, there's no penalty for guessing. You should never leave a question blank. And if tonight you're not sure what the answer is, don't worry. Take your best guess, and Boris will give us an explanation of the correct and incorrect answer choices in just a moment. All right, we've got some responses coming in. We'll give all of you a few more moments here. All right. Well, let's go ahead and take a look and see what all of you selected. It was close, but 40% of you selected B, increases von Willebrand factor. And so in distant second place, we then had D, reduces aquaporin insertion into principal cell membrane. So let's take a look and see what the correct answer is. And the correct answer is indeed B. So great job, everyone. We're off to a good start. Let me hand it off to Boris.
Thank you, Sean. So let's go ahead and let's talk about this one. Great job on this first question, guys. So this is a patient who has polyuria, okay? One day after a brain surgery, okay? And that suggests a diagnosis of diabetes insipidus, specifically central diabetes insipidus, okay? Commonly occurs after many forms of brain surgery. And the reason is you kind of damage the posterior pituitary gland to where it can't secrete ADH, okay? So let's take a look at the next slide. And on that slide, we will see our nice, very extensive table of primary polydipsia and diabetes insipidus, okay? You can see there in the very first line of that, the header of that table, characterized by the production of large amounts of dilute urine osmolality, usually less than 300. Remember, our patient's was 100, so we know that it was diluted, okay? And if you look in the central of that table, central diabetes insipidus, it's caused by decreased ADH release, okay? And one of the causes is brain injury, such as surgery, okay? One of the treatments, if you scroll down, is desmopressin. You can see that the treatment for this is desmopressin. So we figured out step number 1, that this patient most likely has central diabetes insipidus. Step number 2, what's the medication we would give? That's desmopressin. But don't forget, there was a third step to this question. What other effects might it have? And if we take a look at the next slide, we take a look at some of those hypothalamic drugs. You can see desmopressin not only works to treat central diabetes insipidus, but also treats von Willebrand factor. Von Willebrand disease by increasing von Willebrand factor, okay? So desmopressin raises your serum levels of von Willebrand factor by causing it to be released from storage sites in the endothelium. So if we go back to our question and the other answer choices, hopefully you can see now why B is the best answer. There were a few steps to get there, but hopefully you can see how we walked you through that. Now the other answer choices are incorrect. Answer choice E, that's most likely talking about beta-2 agonists and vasodilators such as hydralazine, which is not what we'd use for diabetes insipidus. Answer choice D is talking about ADH antagonists like conivaptan, and that would lead to even more urinary dilation. Okay, so kind of the opposite of what we'd want to do. Answer choice C, lower blood pressure. That could be a lot of different medications. And answer choice A, increases urinary sodium excretion. Also talking about things like diuretics, furosemide, thiazides, but again, not what would treat what this patient has. So great job on this first question.
Well, great job, everyone, and thank you, Paros. Let's move on now to our second question of the evening. Once again, the answer choices are covered up. That is by design, and we will begin with that lead-in. Which of the following is the most likely cause of the patient's elevated BUN? We'll give all of you a few moments here to respond in the question box and let us know how many steps you believe this question will require. Then we'll take a look at that vignette. So once again, which of the following is the most likely cause of the patient's elevated BUN? All righty, let's take a look at that vignette. A 55-year-old man is brought to the emergency department after a motor vehicle accident. Temperature is 37 degrees Celsius, pulse is 140 per minute, and blood pressure is 100/62. Paramedics noted that he vomited blood multiple times during the transfer to the hospital. Physical examination shows trauma to the head, extremities, and abdomen. The stool is heme positive. He is transfused 2 units of packed RBCs because of low hematocrit, with ongoing active bleeding, and undergoes an uneventful operative repair of the fractures. Gentamicin and ceftriaxone are given intraoperatively. The next day, his vital signs are stable, and laboratory studies show a BUN of 42, a serum of creatinine, and a creatinine phosphokinase of 60. Urine output is 100 with normal urinalysis. Which of the following is the most likely cause of the patient's elevated BUN? Boris.
Thank you, Sean. So once again, we're going to go ahead and walk you through this vignette and the lead-in. Okay, and so now you can see this is a much longer clinical vignette. Okay, so it's going to be important that we pick up on all those clues. We don't want to glance over any clues, any sentences, and also it's going to be important that the clues very early on, that we highlight them, make note of them, and that we don't forget them once we get to the very end. Okay, so again, we're told right off the bat, demographics, 55-year-old male. Okay, that's the first thing that you should take note of. They tell us why he's coming in. You know, why is he coming to see the doctor? Why is he in the ER? And in this case, it's because of an accident, a motor vehicle accident. So we know that there's trauma. Okay, so that's going to be important. The next thing right off the bat, they give us vital signs. They tell us about, you know, what the paramedics saw. He'd been vomiting, physical exam findings. Okay, and a lot of things related to, you know, heme positive stool. He's given blood. And then, you know, they're moving on to it chronologically. A lot of things are happening. So he's given transfused blood. He has operative repair of fractures. He's given antibiotics. The next day, they're telling us what his labs look like. So there's a lot of things chronologically going on. So you want to make sure, one, that you're, you know what's happening in that chronological manner. You're not missing any of those clues that could be helpful to what's going on in this patient, because any of those things really could be, the cause here. And you want to make sure that you're interpreting all those lab values appropriately. Okay, especially with renal, you want to know, we've already had urine osmolality, which is a not so common lab value. So they're then asking us about the most likely cause of elevated BUN. Okay, so this patient, you know, we know has an elevated BUN. We've highlighted it there. It's 42. So they're asking us about the most likely cause. So in all of that we read, you know, what's going on in this patient that caused the BUN to be elevated? You know, this is maybe a one-step question, but there's a lot to unpack. Okay, so let's take a look. Let's kind of talk how to approach this. So let's take a look at the answer choices. And what you'll see here, again, are 5 answer choices. And once again, we're going to start at the bottom and work our way up to the top. Okay, so answer choice E, RBC hemolysis in the GI tract leading to increased urea production. D, myoglobinuria. C, bilateral renal obstruction due to traumatic urethral injury. B, aminoglycoside nephrotoxicity. And A, acute interstitial nephritis due to cephalosporins. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds. And I'll read some of those other answer choices because they are a little cut off. So answer choice E, RBC hemolysis in the GI tract leading to increased urea production. C is bilateral renal obstruction due to traumatic urethral injury.
Excellent. Well, thank you very much, Boris. The poll is open. We'll give all of you a few moments here to lock in your answers. Once again, we'll wait until about 2/3 of you have responded. We'll give all of you a few more moments here. And for those of you wondering, next week's topic is going to be cardiology. So we hope to see you here. A couple more seconds here. Let's take a look and see what all of you selected. 40% of you selected RBC hemolysis in the gastrointestinal tract leading to increased urea production. And 25% of you selected aminoglycoside nephrotoxicity. So let's take a look and see what the correct answer is. And the correct answer is indeed E, and 40% of you got it right. So once again, challenging question, but good job. Let me hand it back over to Paris.
Thank you, Sean. Yes, great job on this question as well. Definitely a tough question. Some really good answer choices there that could maybe trip you up as well. So let's talk about this, okay? Now, if we take a look at our labs, we note that the BUN is elevated, okay? But what we see there when we look at those labs is the creatinine is normal, okay? If this were to be an acute kidney injury or some sort of other kidney injury, we would expect the creatinine to also be affected, okay? So what is leading to a solitary rise in urea or BUN, okay? Now we know that this patient is bleeding from in the GI tract. The stool is heme positive, okay? So what can happen is those red blood cells can get broken down in the GI tract. And some of the metabolites include urea being produced as a result that then gets absorbed, okay? And that can lead to high BUN in the blood. One of the other cases like that is if someone eats a very high protein meal, similar scenario. You would have breakdown of protein to urea that gets absorbed, and then you get an elevated BUN level, okay? So that protein, for example, is taken up by the liver, catabolized to urea, and you get an elevated BUN. So the other answer choices here, myoglobin urea, that is something to think about in a trauma patient. But we would see an elevated creatinine phosphokinase, which is actually normal in this patient. And we were also told that the urinalysis was normal. That would not be the case. We would see heme positive urine and possible brown muddy casts. Answer choice C, bilateral renal obstruction due to urethral injury. Again, that would lead to most likely a rise in creatinine. The urine output that this patient has is pretty good, 100 cc's an hour. And if the patient were to have that kind of injury, renal obstruction, we would expect no urine to pass, okay? Answer choice B, aminoglycoside nephrotoxicity, usually occurs after a few days of treatment, not necessarily the very next day. But again, we would also expect a rise in creatinine and muddy brown casts or something else on urinalysis. And lastly, answer choice A, we would also expect a rise in creatinine as well. And usually, again, a few days after giving the medication, not immediately after. So like you guys selected, the best answer choice is E.
Excellent. Thank you very much, Boris. Let's move on now to our third question of the evening on the topic of renal. Once again, we'll begin with that lead-in. A change in which of the following is most likely contributing to this patient's findings? A change in which of the following is most likely contributing to this patient's findings? We'll give you a few moments here to respond and let us know how many steps you believe this question will require before reading that vignette. Alrighty, let's take a look at that vignette. A 75-year-old man with end-stage renal disease is diagnosed with a tibial fracture after he hits his right leg on his kitchen table. He is found to have severe metabolic bone disease. A change in which of the following is most likely contributing to this patient's findings. Paras.
Thank you, Sean. So now we're going to walk you through this question here and what we think the important clues are here as well. Okay, so kind of a little shorter question. And we're told this is a 75-year-old male. Okay, so a little bit of an elderly patient. So we got to think about other things when it comes to the kidneys. And right off the bat, they tell us he has end-stage renal disease. Okay, and he's got a tibial fracture after hitting his leg. Also, they tell us severe metabolic bone disease. So they're asking us about a change in what is most likely contributing to this finding. So I think we've got a couple steps here. I think one, we've got to figure out maybe what's going on with this patient. And then two, without kind of going too much in depth, two, what has changed that led to this patient having that issue. So a couple steps here, I think. So let's go ahead and let's take a look at those answer choices. Once again, we'll start at the bottom. Answer choice E, decreased renal production of 25-OH vitamin D3. D, decreased renal phosphate reabsorption. C, decreased renal phosphate filtration. B, decreased renal calcium filtration. And A, decreased parathyroid hormone secretion. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Well, thank you, Paras. The poll is open, and we'll give all of you a few moments here to respond and let us know what you believe the correct answer is. We have one more question left until our raffle and special offers. So make sure you stick around. You might be our lucky winner tonight. All right, a couple more seconds here. All righty, well, let's take a look and see what all of you selected. 49% of you selected E, decreased renal production of 25-OH vitamin D3. In distant second place, we had decreased renal phosphate reabsorption. Let's take a look and see what the correct answer is. And the correct answer is C, decreased renal phosphate filtration. So a tough question here. Let's all pay attention to Paras.
Thank you, Sean. So let's take a look at this question, okay? So this is a 75-year-old male, okay? And he hit his right leg on the kitchen table. Now, normally, that shouldn't lead to a fracture of your tibia, okay? But we do know that he's got end-stage renal disease. So what could be going on because of the kidney disease on that bone mineral level that would make him prone to a fracture after just a little bit of hitting his leg on the table, okay? And what we know these patients are at risk for is, if we go to the next slide, renal osteodystrophy, okay? This is where renal disease can lead to bone issues, okay? Or secondary and even tertiary hyperparathyroidism, okay? What happens is, in end-stage renal disease, you have a low GFR, and that leads to reduced filtration of phosphate. So your phosphate levels in your blood are high. And that's why sometimes we will give patients phosphate binders when they have kidney disease to lower those phosphate levels, okay? And what happens when you have high phosphate, as you can see there in that middle column, hyperphosphatemia leads to low calcium or hypocalcemia, okay? Because it binds the calcium. They form little complexes. Calcium binds to those anions, okay? As a result, you get low calcium, and that can also lead, as a result, to then bone lesions, okay? That low calcium stimulates PTH production, causing secondary hyperparathyroidism. So now you've got high PTH, which further stimulates bone resorption, leading to more bone disease. So it's a very vicious cycle. Okay, that's why end-stage renal disease has so many complications. So if we take a look at our question and our answer choices, hopefully you can see why C is the best answer. Decreased filtration of phosphate is one of the very first things that happens when you have a low GFR. That phosphate then binds to calcium, which triggers that whole cascade like we talked about. Now the other answer choices, in case you selected that, answer choice E is a little bit of a trick question. End-stage renal disease decreases renal production of 1,25 vitamin D3, not just 25 vitamin D3. That is made in the liver, okay? So remember, renal production is of 1,25, 2 hydroxylated sites. Answer choice D is the kind of the opposite. We're having too much phosphate, and this answer choice is getting at the opposite. Answer choice B, that is not really what's happening. We're not really affecting calcium filtration. We're affecting more phosphate filtration. And again, that would actually lead to high calcium, which is not what we have in this patient. We have low calcium, so also doesn't make sense for that reason. And lastly, answer choice A, also false, because in this case patient, we know that they have secondary hyperparathyroidism, so an increase in PTH secretion that further worsens their bone disease. So answer choice C is the best answer here. If you didn't know that, hopefully you also could have used some of those other answer choices and realized those were incorrect in what this patient has. So another tip for when you don't know exactly the right answer choices to make sure you understand the other incorrect answer choices as well.
Excellent. Well, thank you very much, Paras. Some challenging questions tonight. Let's try to finish strong here with our last question of the evening. And once again, we'll begin with that lead-in. Which of the following is the most likely cause of the patient's rising serum creatinine? Which of the following is the most likely cause of the patient's rising serum creatinine? Once again, we'll give you a few moments here to respond in the question box and let us know how many steps you believe this question will require. All righty, let's take a look at that vignette. A 59-year-old man hospitalized with advanced cirrhosis undergoes a large volume paracentesis for symptomatic relief of ascites. 3 days later, he has a decreased urine output. His urinalysis and renal ultrasound are normal. His urine sodium is 12, and serum creatinine has increased from 1.2 to 3. Administration of 2 liters of normal saline does not change the serum creatinine. Which of the following is the most likely cause of the patient's rising serum creatinine? Paras.
Thank you, Sean. So, this is our 4th question. So hopefully you guys are getting a sense of, what are those important clues in these renal questions. A lot of lab values, a lot of things about urine lab values as well. So make sure you know what those are, how to interpret them, okay? Now we've got a 59-year-old male, okay? And they're telling us that he has advanced cirrhosis right off the bat. And they're telling us that he underwent this paracentesis for his ascites, okay? And now, there's 3 or 4 more sentences about urine output, about urine sodium, creatinine, giving saline, doesn't change the creatinine. So you can see a lot of things about urine and serum concentrations of substances and electrolytes and how to interpret those changes. So that's also, like I mentioned, going to be very important. So if you have a hard time with that, make sure you kind of review that. And so they're asking us, what is the most likely cause of this patient's rising serum creatinine? And we saw, as we highlighted, it went from 1.2 to 3. Okay, so I think we've, you could make the argument this is just a one-step question. What happened from in that question, in that vignette, that potentially is the reason that this went from 1.2 to 3. It might be a little bit better to try to figure out maybe what's going on in this patient. What's the diagnosis? What's what's the picture, the clinical picture, and then 2, based on that, maybe why is the creatinine rising? So it might be better to kind of break it down a little bit into 2 steps. So let's take a look at those answer choices. And once again, we'll start at the bottom and we'll work our way up to the top. Answer choice E, splanchnic arterial vasodilation. D, renal interstitial lymphocytic infiltration. C, necrotizing inflammation of the renal arteries. B, necrosis of renal tubular cells, and A, intravascular volume depletion. So once again, we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Well, thank you very much, Boris. The poll is open. It's our last question of the evening before we do a raffle and have our special offer. Well, let's try to finish strong. We'll give all of you a few moments here to respond and lock in those answer choices. All right, got some responses coming in. I hope we'll give all of you a few more moments here. All righty, well, let's take a look and see what all of you selected. %39% of you selected A, intravascular volume depletion, and second and third place were close between splanchnic arterial vasodilation and necrosis of renal tubular cells. So let's take a look and see what the correct answer is. And the correct answer is E, splanchnic arterial vasodilation, which was, I believe, in second place. So another challenging question. Let me hand it off to Paris.
Thank you, Sean. Yes, definitely a tough question here, but it's a question and a topic that they love to ask on boards because it really separates, those who know their cirrhosis and renal complications from those who don't. So let's take a look at this question, okay? So right off the bat, they told us that this patient has advanced cirrhosis, okay? So what I want you to be thinking about is all of those complications of cirrhosis, okay? Caput medusae, varices, spider angiomas, palmar erythema, everything that can, a complication that can arise from cirrhosis, okay? And if we take a look at the next slide, there's actually a really nice diagram of those complications of cirrhosis in first aid, okay? And if you take a look at the kidneys, renal, can't forget about the kidneys, even though we're talking about the liver, something called hepatorenal syndrome, okay? They love asking about this question, about this topic. So let's take a look at the next slide. Let's try to explain what hepatorenal syndrome is, okay? So this patient had a paracentesis done, meaning fluid was taken out of their belly because of this ascites, okay? So we know that this patient has a lot of fluid and bad cirrhosis. And in cirrhosis, as we know, they have portal hypertension, okay? What that leads to is splanchnic arterial vasodilation, okay? And so basically what it does is it tries to provide blood flow to the gut, essentially. So vasodilation of the splanchnic arteries to provide more blood flow to the gut, okay? But as we know from our anatomy, that splanchnic arterial system is pretty big. There are a lot of blood vessels that feed our splanchnic organs. So what happens if you vasodilate all of those splanchnic arteries? Well, like we said, we're taking blood away from other areas. So now the blood supply to other organs, such as the kidneys, is going to be affected. We're going to be decreasing, essentially, from what the kidney standpoint, the circulatory volume to the kidneys, okay? We're not actually depleting volume from the blood vessels, but to the kidneys, it seems like they're getting low blood supply, and they are, okay? So what happens is then you activate RAS, okay? The kidney sense low blood flow, they stimulate more, constriction of the kidneys, vasoconstriction of the kidneys, and that damages the kidneys because, again, the kidney's not getting enough good blood supply. So it's, again, a vicious cycle in patients with end-stage cirrhosis. Okay, and this is called hepatorenal syndrome because the hepatic system is now starting to affect the kidneys. It's potentially life-threatening. It's one of the indications for getting a transplant because once you've developed hepatorenal syndrome, your prognosis is not good at that point. So if we go back to our question, hopefully you guys can see why answer choice E is the best answer here, okay? Answer choice D Renal interstitial lymphocytic infiltration, not the correct answer here, not an inflammatory condition. Same thing with answer choice C. That might be getting at, again, like, acute tubular necrosis or something, but again, not what we're dealing with here. And again, with any sort of acute kidney injury, we would expect that giving saline would improve the creatinine. Okay, in this case, giving fluid is not going to help the kidney function because this is due to a liver issue, not a lack of fluid. Same thing with answer choice B. And lastly, answer choice A, again, this isn't an issue with not having fluid, because once again, if it was an issue with not having fluid, then giving them 2 liters of saline would help and it would improve the creatinine. But again, this is not the issue. So a tough concept here, but definitely one they love to ask about. So read up on it more in case you're interested. Great job on tonight's renal questions. I will pass it back to you, Sean.
Well, thank you very much, Boris. Great job as always. Next week's topic for all of you to keep in mind is cardiology. We hope to see you here. If you want to review tonight's topics and questions in more detail to make sure you've mastered them, here are the question IDs. You can simply type these in to the RX search field and it'll pull right up so you can review them. So I'll leave them up for a few more moments here so you can take a picture of it or jot them down.